The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening and welcome to a special edition of RX Question Lab. Tonight's edition is a special collaboration between the team here at Question Lab and the Pharm professor as we go into that one topic that students can't get enough of, pharmacology. And to help us work through all of these pharm questions, as well as to provide you with a little bit of that pharmacological foundation, we have the one and only Sean Nanji to lead us through. Sean, tell us about yourself.
Sure. Well, thank you very much, Jeff. My name is Sean. I've enjoyed being a part of USMLE-Rx and RX Coach for the last 3 years or so. Prior to that, I was, had my own online programs in pharmacology, especially, which I started after I was given the wrong medication. So I'm hoping tonight's lecture will be useful and you guys will enjoy it. Thank you, Jeff. So we're going to have a little bit of a background talk and lecture about these medications before we do the questions. So we'll start off first by talking about the parasympathetic system. Now, normally when people watch my lectures, I encourage them to talk out loud, talk to themselves, and repeat after me, because that repetition really does help you learn. So today, we'll have Richard kind of play that role and repeat a little bit after me to kind of help you all hear things multiple times. And if you're in a private place, I encourage you to do that as well. So we'll get started here with the parasympathetic system. Another word for parasympathetic is cholinergic. Another word for parasympathetic is cholinergic. Another word for parasympathetic is cholinergic, and the first 4 letters of cholinergic are C-H-O-L. All right, so another word for parasympathetic is cholinergic, and the first 4 letters of cholinergic are C-H-O-L. This parasympathetic cholinergic system, we know it's responsible for the rest and digest system, right? And that's the opposite of the sympathetic nervous system, which is responsible for fight or flight. And we're going to be talking about medications. And medications normally work on receptors, and most of the receptors in the parasympathetic cholinergic system are muscarinic receptors. Repeat after me. Most of the receptors are muscarinic, okay? And the first letter of muscarinic is M, and so these are your M-type receptors, your M1 receptor, your M2 receptor, your M3 receptor. We don't have a lot of time today. What we're going to do is focus on that M3 receptor, and I'm going to ask you a series of questions. And the answer, I'm going to give you in advance, the answer is going to be M3 for all the questions I'm going to ask you now. So I encourage you to repeat after me when I ask you these questions, and then we'll get into one of our first questions of the night on the topic of pharmacology. So we said another word for parasympathetic is cholinergic, and that in the parasympathetic system, most of the receptors are muscarinic. These are your M-type receptors, M1, M2. We're going to focus on M3. So which receptor can I stimulate or agonize to cause an increase in exocrine gland secretions? The answer is M3. Which receptor can I agonize or stimulate to cause an increase in exocrine gland secretions? That answer is M3. And so if I increase secretions, that means that you will be wet and leaky, which is why cholinergics make you wet. And the opposite of cholinergics, anticholinergics, make you dry. All right. And remember, secretions is also how we stay cool. We sweat, right? That's why anticholinergics also make you hot. We'll talk about that later. So we talked about M3 making you wet. Which receptor can I stimulate to increase gut motility? That answer is M3. I'll remind you once again that M stands for muscarinic, and that's in the parasympathetic cholinergic system. So that M3 receptor so far is stimulating your secretions and increasing your gut motility. And I have a question for you. That question is, if I increase your gut motility, will you be having a frequency or more bowel movements or less bowel movements? Well, if you increase gut motility, you will have more bowel movements, which is why we give cholinergic drugs for constipation and anticholinergic drugs for diarrhea. So far we know that the M3 receptor is making you wet and it's making you go to the bathroom or number 2. Now, which receptor can I stimulate to cause bladder contractions? And once again, the answer is M3, which stands for muscarinic type 3 receptor in your bladder, causing an increase in bladder contractions, which means if you squeeze that bladder, urine will come out, which means, and like it rhymes, M3 makes you pee. So far, M3 is making you go number 2 and number 1 and increasing your secretions. It's all due to that muscarinic type 3 receptor in this parasympathetic cholinergic system. Which receptor can I stimulate to cause bronchoconstriction? That also is the muscarinic M3 receptor. And if I cause bronchoconstriction, will it be harder or easier for you to breathe? It'll be harder for you to breathe, right? Which is why we give anticholinergics for asthma to treat it. Which receptor can I stimulate to cause meiosis and accommodation? And once again, that answer is M3, that muscarinic type 3 receptor in this parasympathetic cholinergic system. So we talked about in the parasympathetic cholinergic system, we talked about how cholinergic's first 4 letters are CHOL, and that will bring us to our first drug in a second. But if you look at medications in this category, you will notice that they all have similar side effects: diarrhea, increased urination, meiosis, bradycardia, bronchospasm, emesis, lacrimation, salivation, sweating. And if you talk about, we talked about all of these receptor effects, and if you look at the comparison, these side effects are simply what we talked about earlier, what these receptors actually do. All right. So side effects of these muscarinic medications, these cholinergic drugs or direct muscarinic agonists, are going to be very similar because they're going to stimulate that M3 receptor that we just talked about. We said that the first 4 letters of cholinergic are CHOL, and that brings us to our first drug of the night, which is bethanechol, which we use for urinary retention or post-op or neurogenic ileus. What is urinary retention? That means your patient is unable to void their urine, they're retaining it, you want to make them pee, and we said M3 makes you pee. And for muscarinic in the parasympathetic cholinergic system, and you see there that bethanechol has CHOL right in it. So it's easy to start learning these medications if you start categorizing them by how they end or similar endings or suffixes or prefixes. And we'll talk about that as much as we can here tonight. So the mechanism here is it acts on the M3 receptor, it activates your bladder smooth muscle and causes you to urinate, and it's resistant to acetylcholinesterase. So what is acetylcholinesterase? Anything that has ACE in it breaks down what's before it. So penicillin ACE breaks down penicillin. Acetylcholinesterase breaks down acetylcholine. So this drug is resistant to being broken down by this enzyme. And with that, I will hand it off to Mr. Jeffrey Downing.
Thank you, Sean. So, okay, now we've covered a good chunk of information, and now we're going to see if we can apply it within the setting of a board style question. So, what we're going to do is we're going to reveal the question, and what you're going to see a couple of things that a little bit different here. First thing, you can go to the next slide there, Sean. Within our approach to questions, we cover up those answer choices. First thing we do is we cover those up. It's a part of our methodology, and the main reason is that we don't want you to see a term or maybe a drug or a concept that maybe you're unfamiliar with, or maybe you're a little bit hesitant about. We don't want you to look at something in the answer choice that throws you off your game. Main thing, what we want you to do is to be methodical. So what we say is, first up, cover up those answer choices. Second, we want you to read the lead in. Okay. And this way, when you're reading the lead in, you're able to, drill into the things that you're going to need to be looking for information about. Okay, so in this case, the lead-in, which is the actual question within each item, in this case is, which of the following adverse effects is most likely to be seen as a result of this medication? Okay, so we read the lead-in, And now we know, okay, we're going to be seeing some adverse effects, and that it has something to do with the patient's medication. It's a good framing technique, and it really kind of helps you kind of calibrate your your question answering radar before you get into it. Okay, so with that, then we go back, and now we can read the vignette. A 50-year-old man in the intensive care unit has been unable to pass urine since undergoing an open colectomy 3 days ago. Bedside ultrasound shows 850 milliliters of fluid in the bladder. The patient is prescribed Bethanechol. So again, the question, which of the following adverse effects is most likely to be seen as a result of this medication? What I'd like you to do is go to the question box and let us know how many steps you think it will take for you to solve this question as I turn it over to Sean. Sean?
Well, thank you very much, Jeff. So this is, they're telling us medication it is, so we've got a little bit of a good clue there. We're probably looking at one additional step here, figuring out what the medication is. We already know, and we've got to figure out what the adverse side effect we can see as a result. And I hope that with what we saw in the slide and the receptors are able to pick up on that. As we uncover these answer choices, we will begin with the bottom and work our way up. And the reason we do that is we start at the bottom and work our way up because we don't want you to be jaded by the answer choices. But before I do that, let me go ahead and show you what we think is important in this in the STEM. Demographic information is always important. So we know it's a 50-year-old man. He's in the ICU, and you can see he can't pass urine. Had an open colectomy, given Bethanechol, and so we really already know the medication. Now we just got to figure out what's going on as a result of this medication. So let's start with answer choice E and work our way up. A lot of students oftentimes start at A and don't go all the way down, and they prematurely select an answer they think is correct, or they see an answer choice that they're unfamiliar with, and they rush to judgment or panic as a result. So let's start always with E and work our way up. E, sensitivity to light. D, involuntary muscle contractions. C, hypertension. B, dyspnea. And A, decreased urinary output. So with that, I believe Jeff is going to go ahead and open up that poll.
That's correct. So we have launched the poll. So take a look at that set of adverse effects. Let us know which one you think is most likely going to be seen as a result of the use of Bethanechol. Now, again, we do remind you that on test day, it is important to answer every question. You're not going to be penalized for wrong answers, but you may benefit from getting lucky, right? So let's see. We've got about almost 2/3 of you have voted. We'll keep the poll open here for just a few more seconds. Looks like we have there's a pretty strong consensus backing one of the answer choices. So, okay, well, it looks like almost 80% of you have voted. So I'm going to close the poll and let's share the results. So almost 60% of you went with dyspnea, and about a quarter of you were kind of split between involuntary muscle contractions and sensitivity to light. So, very good. Let us see what the answer is. I'm going to hide those results. And the answer is answer choice B, dyspnea. Nice work, everybody. Good way to start off tonight's session. If you didn't get it right, that's okay. Sean is going to help break it down for you. Sean?
Well, thank you very much, Jeff. Great job indeed. This is actually a hard question in our question bank, and 60% of you getting it right is amazing. So well done, everyone. We talked about that M3 receptor. We talked about everything it did. And one of the things we said it did is cause bronchoconstriction. And we said that bronchoconstriction makes it harder for you to breathe. And that is why B is the correct answer for this question. Let's talk about why the other answer choices are incorrect. Involuntary muscle contractions, you'll see that if you have, that's not really what these receptors do. The nicotinic receptors will do that. We didn't have time to really talk about that today, or organophosphate poisoning. But once again, if you focus on what we talked about today with that M3 receptor and the mechanism of action of how these drugs work, you can answer the why and what will happen afterwards. As far as sensitivity of light goes, we talked about bethanechol causing meiosis and also accommodation. Therefore, it's really unlikely to cause sensitivity to light. Decreased urinary output, we said that M3 makes you pee, so that's the opposite. We're actually giving them this medication for that exact reason, is to increase that output. So that is the incorrect answer for that reason. And hypertension, hypertension results from stimulation of that alpha-1 receptor. And this is not an alpha-1 drug, it is a cholinergic drug, and we know that because it does have that CHOL in it. So great job, everyone, with the first question. And with that, we'll go ahead and move on straight into the prelude to our second question. So we talked about cholinergics and direct muscarinic agonists, which make you more cholinergic. There's another way to make you more cholinergic, and that is by agonizing these muscarinic receptors indirectly. And the way we do that is by keeping acetylcholine around. How do we keep it around? We keep it around by preventing it from being broken down. And what breaks it down? Acetylcholine esterase breaks down acetylcholine. So if you have a drug that inhibits acetylcholine esterase, that means acetylcholine cannot be broken down, which means you have more acetylcholine, which means you're more cholinergic, and you're more cholinergic indirectly. And a lot of these drugs have the 4 letters STIG in it. And the one drug here we're going to talk about is physostigmine or fixostigmine, which is used to fix an anti-cholinergic toxicity or overdose. So one pattern to keep in mind, and repeat after me if you can: overdose opposite, withdrawal same. Overdose opposite, withdrawal same. If somebody overdoses on something, you give them the exact opposite of that drug to get them out of that overdose situation. However, if they're withdrawing from something, you give them something with the same mechanism of action that lasts a little bit longer to wean them off of it, like we do with methadone, right? So here they are 2 anticholinergic. So we make them more cholinergic. We fix that with fixo or physostigmine, which does cross the blood-brain barrier, which allows it to get where it needs to be. It'll then inhibit acetylcholine esterase, preventing the breakdown of acetylcholine, leaving more acetylcholine in your body, making you more cholinergic, which is then the opposite of anticholinergic, which is what we use it for. So with that, I'll hand it over to Mr. Jeffrey Downing.
Okay, so with that queued up, let's go to question number 2. And again, as always, we are covering up those answer choices, and we will start off with the lead-in. So again, the lead-in here: which of the following is the mechanism of the most appropriate drug to correct this patient's new signs and symptoms? Okay, take a look at that. Quite a bit of information that needs to be synthesized and understood. It kind of helps you frame what you're going to be tackling here as we get to the vignette. So let's read that. A 62-year-old man is brought to the emergency department because of confusion, agitation, and delirium. His wife mentions that a few days ago, the patient decided to increase his dosage of a medication prescribed for urinary urgency, frequency, and incontinence. Yesterday, he started to complain of difficulty urinating and defecating. Temperatures 38.8. Examination reveals tachycardia, mydriasis with inability to accommodate, anhidrosis, and decreased bowel sounds. So again, the question: which of the following is the mechanism of the most appropriate drug to correct this patient's new signs and symptoms? Take all of that in. Let us know how many steps you think it's going to take to come up with a solution to this question as I turn it over to Sean.
Well, thank you, Jeff. So we're going to go ahead and show you what we think are the most important parts of this question. Once again, demographic information, 62 years old, right? He's in the ER, so it's important to note that. That means it's acute. Got confusion, he's agitated, got some delirium. And a few days ago, he increased the dosage of a medication that was given for urinary urgency, frequency, and incontinence. So we're trying to fix this urinary urgency, trying to fix the frequency, trying to fix his incontinence, but he increased the dosage, and now all of a sudden, he's saying difficulty urinating and defecating. So now he's tachycardic, he's got mydriasis, and he can't accommodate, he's got anhidrosis, and he's got decreased bowel sounds. So what's the mechanism and what's the most appropriate drug to correct this patient's signs and symptoms? So we got to figure out, first of all, what state was this person in, what medication were they given, and then what's the mechanism of that medication that we're going to give to fix this situation. So with that, we're going to go ahead and uncover the answer choices, starting at E and working our way up to A like we always do. E stimulates beta-1 adrenergic receptors. D releases stored norepinephrine. C inhibits acetylcholinesterase. B antagonizes muscarinic receptors. Or A antagonizes beta-1 adrenergic receptors. So Jeff is going to go ahead and open up that poll.
Okay, so we have launched the poll. Let us know. You've been thinking about this. There's a lot of information in this particular one. There's a lot connected to this story. So which of the following is the mechanism of the most appropriate drug to help this patient deal with their new signs and symptoms? Okay, we've got, let's see, quite a bit of, gosh, we've got a really strong showing here for one of the answer choices. So looks like the majority of you have already kind of decided, hey, you think you know this one. Okay, let's see. Almost 3/4 of you have voted. So I'm going to go ahead and close the poll. And you'll see that, we'll share the results. Yeah, the answer choice C inhibits acetylcholinesterase, a runaway in terms of votes. About 1 out of 5 of you went with antagonizes muscarinic receptors. So with that, we're going to go ahead and hide the results and reveal what the answer is. And the answer for question number 2, drum roll please, is indeed answer choice number C, or answer choice C, inhibits acetylcholinesterase. Great work, everybody. Again, I think applying the knowledge that you just gathered from Sean helped some of you out. If you got it wrong, though, that's okay. We're going to walk through it for you. Go ahead, Sean.
Well, thank you, Jeff. Once again, a strong showing, and this is a very high yield topic, and I'd love to ask about this. So look at this question stem. What is going on with this patient, right? They had urinary urgency, frequency, and incontinence. So they're peeing too much, right? And what receptor makes you pee? Well, we know that M3 makes you pee. So how do we make you pee less? We block that receptor. How do we block that receptor? We make you anticholinergic or give you an anti-muscarinic. So this patient is too anticholinergic or too anti-muscarinic, so we've got to make them more cholinergic, and there's 2 ways to do that. We can give them a direct cholinergic or muscarinic agonist, or an indirect one just like physostigmine or fixostigmine to fix the anticholinergic toxicity, which will prevent the breakdown of acetylcholine by inhibiting acetylcholine esterase, thereby giving you more acetylcholine and making you more cholinergic and doing the opposite of what this overdose or toxicity is. All right. The other answer choices don't work, and I'm going to explain them to you why. First and foremost, the beta-1 adrenergic receptor, that's just going down the wrong path here. It may help with some of the symptoms, but it's really not going to help a lot. But we're going to, kind of give you a pattern here to keep in mind to keep these alpha and beta receptors straight. So you've got a 1-lane road and you've got a 2-lane road. You've got a 1-lane road and you've got a 2-lane road. This is not a trick question. Which road has more room? The 2-lane road has more room. Which road has less room? The 1-lane road has less room. So now we've got this 1-lane road that we agree has less room, and now you have to name this 1-lane road. So this 1-lane road that has less room needs a name, and you have 2 choices to name this 1-lane road that has less room. And your 2 choices to name this 1-lane road that has less room are either vasoconstriction or vasodilation. Pick one. Well, I hope you said vasoconstriction, and if you did, you're right. And that's how I remember that alpha 1, beta 1, 1-lane roads, less room, cause vasoconstriction and increase your blood pressure. And alpha 2 and beta 2, 2-lane roads, more room, cause vasodilation and decrease your blood pressure. So just keep that trick in mind. Answer choice B, antagonizes muscarinic receptors. Well, that's actually the problem that we're trying to fix, right? Because this person has been antagonizing them already, and they're too anticholinergic or too anti-muscarinic. So we're trying to achieve the opposite of that. So great job, everyone. Strong showing there once again. And with that, we'll do the prelude to our third question. But before we talk about this slide, let's talk about the alphabet. What comes first in the alphabet, heparin or warfarin? What comes first in the alphabet, acute or chronic? So that's how I remember that heparin comes first in the alphabet, and we use that for acute conditions, and warfarin comes later in the alphabet, and we use warfarin for more chronic conditions. So if you look at heparin here, we use it for immediate anticoagulation for pulmonary embolism, acute coronary syndrome, MI, after cardiovascular surgery, for a DVT or for DIC, and for anticoagulation during pregnancy, because it does not cross the placenta, whereas warfarin does. Okay? Heparin will bind to antithrombin 3, and it will decrease the formation of thrombin and factor XA. And it's got a short half-life. So once again, acute conditions, short half-life. It comes before warfarin in the alphabet. Is for acute conditions. It's got a short half-life. Warfarin comes later in the alphabet. It's used for chronic conditions. It's got a longer half-life. Okay? Side effects, well, if you overdose on heparin, you will have increased bleeding, and the reversal for heparin overdose, specifically not warfarin, is protamine sulfate. For warfarin, the antidote is actually vitamin K. And we don't have time to talk about that today, but we can revisit it maybe some other time, or you can view the lecture online at thepharmprofessor.com. So overdose of heparin is treated by reversing it with protamine sulfate. Side effects also include osteoporosis and heparin-induced thrombocytopenia, or HIT. And with that, I'll hand it off again to Mr. Jeff.
Okay, so you know a little bit about heparin and warfarin. You know which one's acute, which one's chronic, right? So here we go. Let's get into question number 3. So again, we have covered up the answer choices. We do have an image here for you to use as a reference. And we're going to start with the lead-in. Which of the following drugs would most likely reverse this patient's coagulation status? So you can see the coagulation taking place in that particular patient there in the image. So with that as a way of getting oriented, let's go ahead and read the vignette. A 73-year-old man is brought to the emergency department by his daughter after a fall at home. The patient is admitted with a left femur fracture, and he is started on anticoagulation. A few hours later, the patient develops ecchymosis on the right thigh, as shown. Laboratory tests show a platelet count of 210,000, bleeding time of 5 minutes, prothrombin time of 12 seconds, and an activated partial thromboplastin time of 50 seconds. So again, which of the following drugs would most likely reverse this patient's coagulation status? Thinking about that, let us know how many steps you think it would take to solve this one. Let us know in the question box as I get ready to pass it over to Sean. Sean?
Well, thank you very much, Jeff. So once again, we're going to show you what we think are the most important clues here. 73-year-old man fell down, got a left femur fracture, and started on anticoagulation. A few hours later, got ecchymosis on the right thigh. Platelet count 210,000. Bleeding time of 5 minutes. Prothrombin time of 12 seconds. An activated partial thromboplastin time of 50 seconds. So which of the following drugs would most likely reverse this patient's coagulation status? Look at that picture there. What do you think is going on over here? And how do we fix it? Answer choice E, vitamin K. Answer choice D, protamine sulfate. Answer choice C, fresh frozen plasma. B, andexanate alpha. And A, amino caproic acid. And with that, I believe Jeff's gonna open up that poll and let's try to knock this last question out of the park.
Okay, that's right. So this is the final question of the night. Let's see if you're able to apply some of that newfound knowledge or perhaps newly reinforced knowledge into answering this challenging question here. So what do you think the right drug is here that would reverse that patient's nasty bruising? Let's see. So we've gotten about half of you have voted. You guys have done a nice job here tonight in terms of voting quickly, not having to prompt you very much. You guys are jumping right into it, which is great, showing quite a bit of confidence. And let's see. So I think we've gotten 3/4 of you have voted. So we're going to close the poll. Let's once again, we have kind of a sort of a runaway answer choice there, and answer choice D with protamine sulfate. Some of you were thinking vitamin K and fresh frozen plasma. So let's go ahead and reveal the answer. So the answer for our final question is indeed protamine sulfate. So again, almost 3/4 of you, a little bit over that, got it right. If you didn't, that's okay. Regardless, we're gonna, the explanation is where, the keys are for success on test day. And to help you with that, here's Sean.
Well, thank you very much, Jeff. So once again, we talked about the alphabet, we talked about acute, we talked about chronic, and right here we know he's in the emergency department. He fell. This is an acute condition. They're going to give this guy heparin, and we know he's on anticoagulation. So right then and there, they're on heparin. That is your clue where if you know nothing else, acute short-term anticoagulation, automatically think heparin. And what do we give for a heparin overdose? We just talked about it, protamine sulfate, and 77% of you got it right. So great job. For those of you thinking warfarin, almost there, but you got to keep in mind that warfarin is not going to be used for acute conditions like this. So keep that in mind in the future, and you will get it right on test day, but more importantly, in practice. So why is vitamin K wrong? Well, once again, fresh frozen plasma and vitamin K, they're both used in the immediate reversal of warfarin toxicity. And you will see that as an elevated prothrombin time, which we don't see here. And you may not have realized that because we didn't post the lab values like they would on your exam. You're able to pull them up. But like I said, you don't really need that for this question if you remember that pattern of heparin acute and warfarin chronic. Okay. Andexanate alpha, answer choice B. That's really used for it'll neutralize the anticoagulant effects of factor 10A inhibitors like rivaroxaban and apixaban, and that's not what we're talking about here, okay? And as a result of answer choice B, you're not going to typically see a partial thromboplastin time being increased, okay? So that's another reason why that's not correct. Aminocaproic acid, that's used to reverse the thrombolytic effects of drugs like streptokinase and urokinase and TPA because it inhibits fibrinolysis. And once again, we didn't get to talk about the mechanism of all those medications, but we will, if you like this lecture style, you're able to actually go online at thepharmprofessor.com, get the book, and it's accompanied with videos, and it's about 11 hours total from start to finish. And of course, we'll ship that book out to you as soon as we can. So, you know, I want to, you know, stress that to you, and we'll give you a little promotion code and a special offer here later, so you can save some bucks on that if you'd like to take advantage of it. So if you want to review these questions on your own time, you've got the question IDs here. You can take note of them. Simply go to USMLE-Rx, type it into the search field, and pull these questions up to get a better review. Before I hand it off to Jeff, you know, we've all, I'm sure, encountered our fair share of mentors and people who guide us, and I consider myself very lucky to have mentors like Dr. Towley and Jeff Downing, who really, you know, they're really passionate about what they do, and they really care about helping you become a successful physician. And I think, you know, oftentimes students don't see all the behind-the-scenes efforts that the people behind USMLE-Rx and First Aid put in to make sure that you are successful. And I just want to remind you that, you know, how lucky we are to have people that are producing resources like this for us, and especially me for having mentors to look up to like Dr. Lee and Jeff. So with that, Jeff, I'll hand it over to you.